So we touched upon a couple of supplements, and the supplement in the industry is probably as big as the pharmaceutical industry. There is a lot of benefit, and a couple of supplements that could, actually make a difference, perhaps long term. And garlic, you mentioned a few omega 3 fatty acids, coenzyme Q. What are your go to supplements, and how would you rate a couple of supplements that, okay, these do have a proven efficacy and safety regards to cardiovascular health?
So I always love the question, but there are no go-to supplements. They're just, when people have certain deficiencies, and if they don't get it through their, exercise, their nutrition, then you replete them back up to optimal ranges. You know, but we talked about earlier, the three big buckets, what can support nitric oxide availability? There's a couple supplements that can give you nitric oxide if your body isn't producing enough of it. There's supplements that help support the endothelial glycocalyx. So if the protective coating is damaged, you can give a supplement that gives the body the building blocks to put down more of the endothelial glycocalyx. So putting the force field up. There's multiple supplements that can help lower inflammation, omega-3 fatty acids. Curcumin can help with it, lowers TNF alpha, lowers CRP. And then the lipoproteins, I mentioned a couple. There's bergamot, which acts like a statin. It's lowering HMG co-reductase. Berberine is a weak oral PCSK9 inhibitor, also has effects sort of like metformin at lowering blood sugar. Those are kind of some of the lipid ones that sometimes we will utilize. CoQ10, especially if a person has, a cardiomyopathy or they have a lot of muscle symptoms on statins. A lot of times CoQ10 might be able to help with that because it's helping support energy production in the mitochondria. Magnesium is often important for many cardiac patients. If you have high blood pressure, palpitations, atrial fibrillation, heart failure, magnesium deficiency is not uncommon. So you want to replete them back up with magnesium until their symptoms go away. So those are some of the starting points that we utilize in our practice. But we're checking comprehensive blood work people and then fine tuning things based off the blood work.
Right. Do you check omega 3 levels, perhaps? Do you differentiate between the two varieties in your practice? Does that go into your adjustments, whether you give patients or not?
Correct. Yeah, I'm looking at the mega check levels and then looking at the specific EPA and DHA levels. And the DHA is critically important, especially in patients with ApoE4. You need DHA to be able to transmit energy in your neurons. So without DHA in your brain is like at half power essentially. I sometimes joke with patients that your DHA level is essentially your cell phone charge. You want it to be at 100% so that your brain can work at peak capacity all day long. And I like to see omega-3 to omega-6 ratios, generally be in the 4-to-1, where you have no more than 4 times the omega-6 to omega-3s.
Right. How often do you recommend people eat cold water fish, salmon, perhaps? How often do you recommend that? Or do you look to rely more on supplementation to fix any deficiency?
No, that's definitely why I like that question. Is that it should be coming through dietary sources because the body has a way of processing the electrons coming from cold water fish, and it may be completely different than the fish that's in a capsule. Once man-made processes come into play, you don't know exactly how it's going to be absorbed. So I much prefer people actually eat the seafood than supplementing with it. Doesn't mean that I don't supplement people with it, but I always want them to start with eating nutrition first. And so you can do the smash salmon, mackerel, anchovies, sardines, herring, throw in tuna as well. And 2-3 times a week is kind of the bare minimum, and then monitor blood levels.
And I believe you mentioned coenzyme Q, perhaps. In, I think, medical literature, it's been effective for heart failure patients, and patients' heart is fairly weak in the classification. However, it is used very commonly, generally, and its supplement is available, of course, easily on Amazon. How do you go about with coenzyme Q, perhaps?
Sure. And off the top of my head, I can't remember the name of the trial. I want to say it was like Q Symbio trial, where they were adding on CoQ10 to patients' standard of care heart failure regimen. So the patients are on maximally tolerated beta blockers, ACE inhibitors, and medications like spironolactone, and they're adding on CoQ10, and the patients had less, hospitalizations, and I believe even mortality benefit with it. But coenzyme Q10, just really want to get one that's in a gel capsule. The dose, I mean, it's a rough estimate that you need about 100 milligrams of CoQ10 for each drug that you're on that depletes it. So if you're on a beta blocker, that's going to deplete CoQ10. If you're on a statin, that's going to deplete CoQ10. So you need about 100 milligrams of CoQ10 for each medicine that depletes it. then add on another 100 milligrams. So often, CoQ10 is between 100 and 300 milligrams a day, but you're mostly doing it to get blood levels generally above the value of 3.
No, definitely. Okay. So a couple of things that translate into what most cardiac patients may need to consider and talk to their doctor about it. Thanks for watching, and I appreciate you as a valuable viewer. And if you liked this segment, you can watch all of the different individual segments or the whole podcast to have a broader understanding on this topic. Just check the links in the description or what you see on the screen right now. I'm Dr. Umar Khan. Looking forward to seeing you again. Thank you.